Dr. Rashmin Gandhi.
Yeah, a very good morning to everyone. I'll be talking about injecting a mixture of dexamethasone and triamcinolone in the retrobulbar space in cases of optic neuritis. So most of our conventional wisdom comes from optic neuritis treatment trial, which says that if we give IVMP, it hastens the visual recovery but does not affect the final visual outcome. And giving oral steroids at the routine dosage may actually be more harmful to the final visual outcome. So this is your classic optic neuritis patient, and these patients generally do not have any comorbidities. You can safely give them IVMP, and most of the Indian population does not have multiple sclerosis, and good visual recovery is generally seen after the first episode. But the problem was appreciated when we were working in tertiary care hospital, and we started getting lots of patients who had comorbidities which prevented them from receiving IV methylprednisolone. They were walking in from non-neurological wards like rheumatology patients, even from endocrine and nephrology department, where we saw an overlap between the optic neuritis and NAION spectrum, where even a 70-year-old patient proved to be a confirmed case of optic neuritis on serology. And we were also getting atypical optic neuritis patients from neurology ward like NMO and MOG positive patients. So we had patients who were not candidates for IVMP. There was existing evidence that the peribulbar and retroorbital space can be used for delivering drugs. This stemmed from the COVID pandemic associated orbital mucormycosis, where we were injecting antifungals in these spaces. The peribulbar space was not very ideal for injecting steroids because the concentration of drug will reduce by R2⁴ factor. So we chose the retrobulbar space as the ideal route. And which drug to use? So we had dexamethasone, which was faster acting, but within 48 to 72 hours, it is disappearing from the extracellular space, and the implants could not reach that space, whereas the triamcinolone was slightly slower acting. So we decided to make a cocktail of the two in a 2 ml mixture and use it. So these were our first three cases where we had a nephrotic syndrome patient who was already having secondary diabetes mellitus, walked in with right eye vision of 3/60. We tried this technique, and within 3 days, visual recovered to 612. Final BCV was 6.9. We had another breastfeeding women who had recovered from preeclampsia, had recent malignant hypertension, could not be given IVMP. With 660 vision, she improved to 6/9 in 24 hours with final visual acuity of 6.6. And lastly, we had a lupus nephritis case. In this case, there was again 1/60 vision, which improved to 6/12 with this technique. We became bolder and tried it in our atypical optic neuritis patient. Till now, we have used it in two patients. First was a 17-year-old boy. He had his board exams going and he could not be admitted for administering IVMP. And he insisted that you treat me on OPD basis only. And luckily for us, the patient recovered to 6/9 in 24 hours with final visual acuity of 6.6. And another MOG positive patient, right eye had already undergone optic atrophy. The left eye had a presenting vision of 4/60. We tried this and the vision recovered. This patient did not want to go through another IVMP cycle. So we huddled up with our neurologist to find out that what was happening. They said that the bolus dexamethasone was saturating the nuclear RNAs and was triggering an anti-inflammatory spike sufficient to break the cascade. They questioned the role of triamcinolone. So we sat down and we decided that what we need to do is study about this with all the serological, CSF, and neurological workup for each and every case. So this is the study we have designed. Till now, we have had 7 patients in each arm, 12 patients we require to reach sample adequacy, and the results we'll come out with subsequently. Thank you so much. And I'm so pleased that Dr. Rashmin is here. He was the first person to take our class in FMC long back on optic neuritis.
So it's a good thought. It has been tried in the past that can you avoid systemic IVMP altogether, and before MRI or before serological test, this was probably even more popular. My apprehension is that if at all, if you say that this is proven, the indication for this would be very limited because MOG or NMO, they are all the diseases which are manifesting in optic nerve, but these are not optic nerve diseases. I mean, it's just optic nerve is one of the organs which is reacting to something which is circulating in the blood.
Very true.
So, a local treatment for a systemic disease is something which may not work out. In fact, all these antibody mediated disorders, optic nerve effect is your first signal that it might now go and attack spine or somewhere else. And it becomes an emergency in a lot of these patients to say IV not only IV steroids, but immunosuppressives or even plasmapheresis. So you might have to initially, if it first is to prove efficacy that this is
Very
what
true.
worked and nothing else, uh, choose very judiciously and see if that is get approved, and if you're able to publish it, then it will be a good value add. But I think road ahead is a little longer.
Thank you so much, sir. Thank you for the comment.
Thank you, Dr. Pradeep. You can collect your certificate.
Next, we request Dr. Anand Parthasarathy to present his study on intraoperative hacks for anterior lamellar keratoplasty.
We discussed. Good morning, everyone. Can I have my slides? Okay. Video as well. So the ideas for this came when we described two intraoperative hacks to help improve the good results in a lot of these patients. So the reason this is predominantly for anterior lamellar keratoplasties, and the reason that we need to make sure that we get good results is that over a period of time we have found that if you're able to mark the cone, and this is important for deciding the size of the trifine, and the dilated pupil actually gives the extent of the ectatic cornea, both the irregular epithelium, which is a very consistent finding, and the altered contour, along with of course the iron deposition ring that we know about, seen at high magnification. So what we do is just normally for lamellar keratoplasties, you do not dilate the pupils. But in this patient, we actually put drops and dilate the pupil. What that gives you is actually the extent of the the keratoconus. What this helps is that when you're actually operating, you select the trifine to include all the cone. Now, the estimation, if you underestimate what is the risk is that you would end up with a recurrence at the margin of the graft. The second small hack that we've started doing is a small bubble, which is basically important to make sure you have the big bubble, and this will help to improve the success of the big bubble technique in lamellar keratoplasty. So this is a big bubble injection. You've got the big bubble now. You put a small bubble in the anterior chamber. This actually goes around to tell you the extent of the big bubble, and you can then confidently go and release the big bubble. With the release of the big bubble, you can see the small bubble coming in. This actually helps to make sure you get the Descemet's bearing. Thank you so much.
Since Dr. Swapna Noyer is not there, judges can ask questions. Any?
I informed the scientific committee that we had changed the topic for intraoperative hacks from the intraoperative OCT.
It's not mentioned here.
Okay, I had informed them.
Can we evaluate?
I'll just ask. You can evaluate, sir. I'll just ask Dr. Chitra Ramurthy.
I had informed the scientific committee and Dr. Grover.
When?
Yesterday.
No, but this is with the ARC.
Okay, I have not mailed her. I had mailed the China because the mail came from the scientific committee.
Fine, sir. So you can collect your certificate. I request Dr. Kumar doctor to hand over the certificate to him. It's just a name, sir. It doesn't have it.